Welcome to the Deep Dive. We are here to take your source material, the core knowledge you need, and distill it into critical, memorable insights.
And today, we are undertaking a deep dive into an absolutely essential area of community health practice, the nurse in the schools.
That's right. For those of you studying public and community health nursing, it's a foundational specialty.
It really is. So let's define it right away. We're talking about a specialty practice that focuses on providing healthcare and illness prevention.
With one main goal, right?
Exactly. The overarching goal is to facilitate the students' full participation in their educational opportunities. And, what's crucial here is that school nursing is inherently population-focused.
Okay, so not just about one kid with a scraped knee.
Not at all. It's applying these big public health concepts to prevent illness and stop disease from spreading. And not just within the school, but across the entire family and the wider community.
And as we're going to explore, that complexity it's ballooning. It's making the role more autonomous, more demanding.
So our mission today is really to pull out that core knowledge you need for real-world practice. We'll be looking at the legal mandates, the really diverse roles, and how those three levels of prevention actually work in a school.
And to give everyone a sense of the scale we're talking about, it's pretty staggering.
It is. I mean, think about this. In 2020, we're looking at an estimated 56.4 million school children, both public and private.
Wow.
And then you add another 3.7 million teachers, administrators, and staff who also, rely on the school nurse for care and guidance.
And the type of care isn't what people might picture.
No. The spectrum is just immense. It shifts from, minor first aid for a scraped knee all the way up to incredibly complex technology-dependent care. We're talking about managing a child on a ventilator in a school.
That completely reframes the role. It's not an extra, it's a necessary public health mechanism.
Right.
But to understand how we got to ventilator management in a school clinic, we kind of have to look back. The history here is so much more than the old just giving out Band-Aids stereotype.
Oh, absolutely. The very beginning of this formalized role, you have to go back to the late 1800s in England.
In London, right.
That's where it started. The Metropolitan Association of Nursing started providing medical exams for children in schools. And then by 1892, nurses were expanding that. They were checking the nutrition of students.
So even back then, it was about wellness, not just sickness.
Exactly. An early focus on population health indicators going way beyond just acute illness.
That's really interesting. But the big turning point, the moment that really cemented the need for school nurse here in the U.S., that came from New York City and the famous Lillian Wald.
Absolutely. The year was 1902. Lillian Wald, from the Henry Street settlement, she spearheaded this revolutionary idea. Before her, the system used physician inspections, which were, frankly, they were costly and they weren't working.
And she argued for nurses instead.
She did. And initially, her Henry Street nurses went into just 4 schools. They were caring for about 10,000 students.
So what was their immediate mission? What were they told to do on day one?
It was simple. Prevention and control of infectious disease. That was it. They would assess ill children for all the things that were rampant back then, severe lice, infected wounds, even tuberculosis.
And the result?
It was immediate, and it was undeniable. By assessing and intervening right there on the spot, they just dramatically cut the spread of infectious disease. Absenteeism plummeted.
Wow.
And that rapid impact, that data, established the absolute necessity of having nurses consistently in the school environment.
So it was a powerful, very visible demonstration of public health in action. How quickly did the role start to evolve beyond just communicable disease?
Oh, very quickly. By 1910, Teachers College in New York City already had a course on school nursing.
That was fast.
It was. Through the 1920s, a lot of school nurses were actually employed by municipal health departments, which really highlights their public health status.
Right.
By the 40s, that shifted more to school districts employing them directly.
And they were doing more than just clinic work by then.
Oh, yeah. They were providing home nursing. They were actively doing health education for both the kids and their parents.
And then after World War II, the whole landscape it shifts again. I'm guessing things like immunization and antibiotics played a huge role.
A massive role. The crisis of infectious disease, it was never gone, but it became less acute.
So the focus pivoted.
Precisely. School nurses moved away from that constant infectious disease management and more toward large-scale secondary prevention. We're talking mass screenings for things like vision and hearing problems.
And interestingly, the role expanded to cover employees, too.
Yes. They started focusing on employee health screening teachers and other staff for their own health issues. And that set a really early precedent for the nurse's role as, like, a health consultant for the entire school population, not just the students.
So we really see this incredible adaptation from fighting TB in the 1900s to mass screenings in the 50s, all the way to the highly complex environment we have today. That adaptability is just core to the specialty.
It really is.
And that historical evolution brings us right to the modern era. The role didn't just grow organically. I mean, it exploded because of major federal mandates that started in the 1970s.
Yeah.
These laws basically required schools to accommodate children with disabilities, and that fundamentally changed who was in the classroom and, by extension, the clinical complexity the nurse has to face every single day.
These laws are the absolute bedrock of modern school nursing practice. Any nurse going into this field, you have to know these inside and out. And the first key piece of legislation was Section 504 of the Rehabilitation Act of 1973.
Okay, so walk us through that. What was the immediate necessary effect of Section 504?
It was a game changer. It stated that any public school getting federal funds could not discriminate against someone based on a handicap.
Okay.
But more than that, it required the school to provide reasonable accommodations. And that included needed health services to make sure the child could actually access the educational environment.
So this was the first time schools were legally required to provide health care.
The very first time. And that idea, providing services in the most inclusive environment, that paved the way for the next big one. The Education for All Handicapped Children Act of 1975.
Which we now know as IDEA, right?
Correct. It later became IDEO in 1997, and then IDEA in 2004. The Individuals with Disabilities Education Improvement Act.
And what did that mandate?
It mandated that disabled children from birth all the way through age 22 must get services in the least restrictive environment.
So for a lot of medically fragile kids, that meant moving out of specialized institutions and into a mainstream classroom.
Exactly. And this is the moment where nursing responsibilities get enshrined in federal law. It required these highly specific clinical and educational plans.
Right, the IEP and the IHP.
Absolutely. So you have the Individualized Education Plan, the IEP, which is about educational goals, but the nurse is primarily responsible for the Individualized Health Plan, the IHP.
And that focuses purely on the health needs.
Purely. What procedures they need, when they need them, how emergencies will be handled. So suddenly nurses are managing kids with complex chronic conditions, HIV/AIDS, kids needing ventilator support, right there in an elementary school.
The jump in complexity and the sheer amount of documentation must have been enormous.
It was.
Okay, let's fast forward a bit to the Every Student Succeeds Act, or ESSA, from 2015. It replaced No Child Left Behind. What did that mean for school nurses?
ESSA really strengthened the requirements for supporting vulnerable students, kids with disabilities, those in poverty, kids with limited English proficiency.
But the key insight here for the nurse is about funding, isn't it?
It is. ESSA requires states to allocate federal funds specifically toward activities that support safe and healthy students. And this gives the nurse incredibly powerful leverage for budgetary advocacy.
So instead of health services being seen as this optional, nice-to-have thing,
Right.
ESSA ties federal money directly to the nurse's leadership role in promoting health and safety.
Exactly. It makes the nurse an indispensable partner in getting those resources. They can use their data, like showing how attendance rates improve because of their case management, to argue for more funding for school health services, all under the ESSA mandate.
It connects the health outcome directly to the educational funding outcome.
A direct line.
And we also have mandates that are focused on prevention through nutrition. I mean, it's a basic concept. A kid can't learn if they're hungry.
And that falls under the Child Nutrition Act, the CNA, which was first passed back in 1964.
That's what established things like the National School Lunch Program.
Yes, and school breakfasts, summer food programs, huge federally supported initiatives. And then the 2010 reauthorization, the Healthy Hunger-Free Kids Act, or HHFK, just amplified all of this. It set minimum nutritional standards and required schools to limit access to non-nutritious foods.
And the nurse isn't just an educator here, they're a policy advocate.
Yes, because the HHFK required schools to create local school wellness policies. And the school nurse, as the health expert on site, has to help develop and enforce those policies. It reinforces that core public health idea. A healthy, well-nourished kid is a kid who's ready to learn.
Okay, so managing all these IHPs, chronic conditions, all this sensitive personal history, it means the nurse is handling a ton of confidential information. Let's clarify the difference between FERPA and HIPAA in a school.
This is a point of constant confusion, so it's a great question. The Family Education Rights and Privacy Act, or FERPA, from 1974, is the main driver here.
Not ICA.
Not usually.
Yeah.
FERPA specifically covers the educational records of children in federally funded schools. And in most public schools, the student health records that the school nurse keeps are considered part of that educational record.
So they fall under FERPA protection.
They fall under FERPA.
So where does HIPAA, the Health Insurance Portability and Accountability Act, come in?
So HIPAA generally governs protected health information, or PHI. That's held by what are called covered entities, hospitals, private medical practices. In many schools, the nurse is not considered a traditional covered entity under HIPAA.
So FERPA is the rule of the land for school records.
In most cases, yes.
That sounds like it could be a bureaucratic nightmare. How does the nurse balance privacy with the need to, talk to an outside doctor about treatment?
This is where their clinical judgment and some specific regulatory clarifications are key. The USDHHS put out a really important statement back in 2008.
And what did
It clarified that protected health information can be shared between school nurses and primary providers when it's necessary to coordinate care and make treatment decisions.
So it's allowed, but with guardrails.
With major guardrails. The nurse has to get the appropriate consent to facilitate that exchange, always prioritizing continuity of care while, maintaining the strictest possible confidentiality.
So that legal landscape just confirms how mandated, how accountable this field is. Okay, moving from the legal framework, let's talk about the professional standards that guide the actual day-to-day practice.
The main professional body here is the National Association of School Nurses, or NASN. Their mission is pretty straightforward: to optimize student health and learning by advancing the practice of school nursing.
And they established the foundational document for the specialty.
They did. It's called the School Nursing Scope and Standards of Practice, and it was most recently updated in 2017.
So how are those standards structured to guide such a complex job?
They're broken into two main sections. The first is the Standards of Practice. This is what every nursing student will recognize. It follows the standard nursing process.
Assessment, diagnosis.
All of it. Assessment, diagnosis, outcomes, identification, planning, implementation, and evaluation. It's all there to ensure clinical rigor in every single interaction.
And the second part, the standards of professional performance, that outlines the sort of bigger picture responsibilities.
Exactly. These are the competencies you need for such an autonomous role. Things like adhering to ethical practice, maintaining confidentiality, navigating that FERPA-HIPAA maze, demonstrating cultural competence, and wisely using resources.
And it also mandates that the nurse is a leader.
Critically, yes. These standards mandate that the nurse actively engages in school health services, program management, and leadership, both within the school and out in the community.
That emphasis on program management really points to a high level of autonomy, which brings us to education. What's the professional recommendation for entry into school nursing?
The consensus from both the NASN and the American Academy of Pediatrics, the AAP, is very clear. The minimum professional recommendation is RN licensure and a bachelor's degree in nursing, a BSN.
And why the BSN specifically? Why not an associate's degree?
Because the role is fundamentally a form of public health nursing. School nurses are managing entire populations of children and staff, often with no direct supervision. And their health issues affect the whole community. So the practice demands really high autonomy, expertise in population-level assessment, policy development, critical judgment, all of which are core components of a BSN education.
So the BSN isn't just a preference, it's a reflection of the public health skill set that's required.
That's a perfect way to put it.
Do state requirements vary on this? And what about advanced practice nurses, APNs?
State requirements do vary, which is, unfortunate. It sometimes leads to schools employing nurses who don't meet that BSN standard. However, the role of the APN is definitely expanding.
Especially those specializing in pediatrics or family nursing.
Yes, and often holding master's degrees. They often staff what are called school-based health centers, or SBACs.
So what unique services can an APM provide in a school that really gets at those social determinants of health?
Well, they can provide primary care, preventative screenings, often mental health services right there on campus.
Yeah.
This is just revolutionary for community health.
It improves access immediately.
Immediately. For families who might lack insurance or a regular doctor, or even just reliable transportation, it removes huge barriers for working parents who might otherwise have to take a whole day off work for a routine physical for their child.
So the APNs are leveraging the school as a primary health access point. They're cutting down on the friction for the whole family.
Exactly. They're integrating care delivery right where the kids are, which is a major component of any effective population health strategy.
Okay, here's where it gets really interesting for me. Moving from the legal structure to the daily function, the school nurse wears just a remarkable number of hats at the same time.
Hmm.
The sources break it down into 9 essential roles. Let's start with the one most people think of, the direct caregiver.
Right. And as we said, this goes so far beyond just ice packs. The nurse has to apply really complex clinical assessment skills to stabilize students in emergencies and to provide ongoing care for chronic illnesses. They're the frontline medical expert on that campus.
But it's the clinical complexity that truly sets the modern role apart. Give us some examples of the kind of technical care they might be providing.
We're talking about highly technical procedures, things like intermittent catheterization, administering meds and fluids through tube feeding devices, tracheostomy suctioning, and care.
Wow.
And even managing children who rely on complex machinery
Hmm.
like ventilators. It's basically critical care, but outside of a hospital.
And sometimes if the needs are that intensive, the district might hire a private duty nurse just for that one child.
They might, but the school nurse still oversees and coordinates that entire plan of care.
And you mentioned residential settings like boarding schools or detention centers. What's different about the caregiver role there?
In those places, the nurse is providing care 24/7. They're often living on site or they're continuously on call, so they're managing the entire health ecosystem of that population: sleep, nutrition, medication, well-being, everything.
Okay, role number 2 is the health educator.
This is all about planned, sequential teaching. It can be one-on-one or in the classroom. The topics are usually dictated by public health needs and state mandates. So injury prevention, dental health, puberty, substance abuse.
And a big piece is educating the parents, too.
A huge piece, educating parents on how to manage their child's chronic illness at home so they have the tools to be effective.
Third, the case manager. This sounds like the organizational backbone of complex care.
It truly is. It's a core public health function, all about coordination. The nurse is the central hub. They're collaborating with the family, the teachers, administrators, and all the outside therapists, physical, occupational, speech.
And they're making sure those individualized health plans, the IHPs, are actually working?
Exactly, that they're developed, communicated, and integrated into the student's daily schedule so that the treatment is seamless and their learning is maximized.
Okay, the fourth role, the consultant. This positions the nurse as the health authority for the entire school.
Yes, they're providing expert professional information to administrators, staff, parent groups. And this is often where that population-level policy influence happens.
Like recommending changes to safety protocols.
Exactly. Or advising on communicable disease policy, or even engaging community organizations to improve the collective health of the whole population.
Fifth is the counselor, and this is a role that apparently takes up a surprisingly large amount of their time.
It does. Research shows that school nurses can spend up to a third of their time on mental health needs. They are seen as these trusted, familiar, safe figures
So kids confide in them.
about really profound issues: bullying, abuse, grief, body image concerns, even suicidal thoughts. The nurse has to be so adept at recognizing when these vague, frequent complaints, the headaches and stomach aches, are actually signs of underlying emotional distress.
That is an incredible responsibility, and it must require just acute sensitivity around confidentiality.
It really does.
Yeah.
They have to build trust by emphasizing confidentiality, but they also have to be completely honest about the mandatory reporting requirements when a situation involves danger to the child or to others. It's a fine legal and ethical line they walk every single day.
Next up, community outreach. This is about stepping outside the school walls.
Pure public health networking. They're in health fairs, they're coordinating with local dental clinics or ophthalmologists to offer free screenings on campus for kids who need them.
And they're active in community coalitions.
Very active. Things like violence prevention groups, youth services, local anti-poverty initiatives. They might even be organizing weekend backpack food programs to directly address food insecurity for their students.
The seventh role is researcher, which is all about evidence-based practice.
Right. School nurses have to be critical consumers of research to make sure their practice is effective. And the sources cite a really important review finding.
Would you?
The presence of a school nurse is directly linked to reduced absenteeism and missed class time.
That is a crucial piece of data.
It's crucial because it gives the nurse concrete data that links a health outcome to an educational outcome. And they can use that to advocate for more resources and more staffing.
It's a powerful argument when you can show a school board that hiring a nurse is an investment in attendance and academic performance, not just a health expense.
A very powerful argument.
And finally, rounding out these roles is the program manager or leader.
This really just summarizes the need for autonomy and high-level skill. The nurse isn't just executing care, they're managing an entire school health program setting policy, running budgets, training staff, and advocating for the needs of their population.
So with all those roles in mind, let's look at the frameworks that kind of pull them all together. The whole school, whole community, whole child model, the WSCC model is key here.
It is. This model, which is championed by the CDC Healthy Schools Initiative, it moves beyond just a list of services. It focuses on how every single aspect of the school environment has to align to support the student.
And at the very center of that model is the child.
The child. The goal is that the child is healthy, safe, engaged, supported, and challenged. And to hit those 5 tenets, the school has to coordinate policy, process, and practice across the board.
So let's talk about the 10 components that define this holistic framework. How does a nurse influence them? Let's start with health education.
The nurse designs the curriculum, making sure it's evidence-based and tailored to what the students actually need.
Okay, physical education and activity.
They consult on that, ensuring a comprehensive program is in place.
Nutrition, environment, and services.
The nurse advocates for healthy meal programs and advises on food policy, like what's in the vending machines.
Health services.
That's their core domain: direct care, prevention, case management.
Counseling, psychological, and social services.
Here, the nurse is the primary screening point, referring students to counseling and other psychological services as needed.
Physical environment.
This is a big one. The nurse assesses building safety, indoor air quality, noise levels, even how chemicals are stored.
Social and emotional climate.
They support a safe, supportive environment, often leading anti-bullying and mental health initiatives.
Employee wellness.
They advise on staff, healthcare, screenings, and worksite safety, often based on OSHA guidelines.
Community involvement.
That's the coalition building, assessing community needs, and linking the school to outside resources.
And finally, family engagement.
Making sure families feel welcome, involved, and educated, while always respecting those privacy mandates, like FERPA.
That really highlights the integration challenge. The nurse has to bridge all these different silos. How is this comprehensive approach evaluated in the real world?
It's evaluated through something called the School Health Policies and Practices Study, or SHPPS. It's done periodically, and the 2016 SHPPS gave us some really crucial data.
What were some of the key findings from that study? What are the ongoing challenges?
Well, one major concern was a significant decrease in the number of school districts with arrangements for school-based health centers, the SBHCs.
And that's a problem because, as we said, those are vital access points for vulnerable kids.
It's a huge problem. Losing them just increases barriers to care. Another critical finding was the low participation in physical activity. Fewer than half of U.S. students were getting the recommended 60 minutes a day.
But there were some positive trends, too.
Yes. A really strong positive trend was that about 80% of districts prohibited all tobacco use, and that includes vaping and e-cigarettes, by anyone on school grounds during school hours. Security measures and anti-bullying programs were also way up.
And all of this feeds directly into the larger national health strategy, Healthy People 2030.
Absolutely. The objectives of Healthy People 2030 are deeply reliant on effective school health programs. Objective AHR08 specifically aims to increase the proportion of secondary schools with a full-time RN.
And the school nurse is central to that.
Central. Same with Objective ECBPD-01, which is about increasing case management for chronic conditions. The school nurse is the key figure in achieving both of those critical population health goals.
And looking to the future, the NASN has another framework to guide development.
Right. The framework for 21st century school nursing practice. It puts the core mission students who are healthy, safe, and ready to learn right at the center.
And that's surrounded by 5 key professional practice domains.
Yes. The domains are care coordination, leadership, quality improvement, and community public health. And they are all implemented through the foundational standards of practice. This framework really emphasizes that the modern nurse isn't just a care provider. They are a systemic change agent.
So they're leading policy, improving quality, and viewing the whole school through a public health lens.
That's the goal.
With those frameworks established, let's move into the cornerstones of public health practice, the 3 levels of prevention. We'll start with primary prevention. This is all about health promotion and protective measures before anything bad happens.
Right. The focus here is on keeping healthy children healthy, and the strategies usually fall into a few buckets. injury prevention, substance abuse prevention, chronic disease risk reduction, and, of course, immunization monitoring.
And the primary delivery method for this is health education. But what are the challenges in actually reaching the target audience?
Well, the biggest challenge in primary prevention often isn't the student, it's the parent. The nurse has to get creative to make information accessible.
So, using school newsletters, websites.
All of that,
Yeah.
and presenting at PTA meetings. But a really effective public health tactic here is removing barriers for families to engage,
Like what?
like providing food or babysitting during a parent health education session. If you do that, you dramatically increase the chances that families with low incomes or demanding work schedules will actually show up.
That makes perfect sense. Okay, let's get into the specific focus areas, starting with preventing childhood injuries.
This is a huge public health priority. Unintentional injuries are, tragically, the leading cause of death for kids and teens. The nurse has to be an educator, using evidence-based guidelines from places like the CDC, covering everything from seatbelts and helmets to water and fire safety.
And their role goes beyond just teaching. They have to assess the physical safety of the school itself.
Absolutely. Playground injuries are a really serious concern. Over 200,000 injuries to kids under 14 every year.
Wow.
So the nurse has to be familiar with and use guidelines from the U.S. Consumer Product Safety Commission to make sure the playground equipment is safe, proper surfacing, the right height, enough spacing. And they collaborate on sport safety too.
Okay, next up, substance abuse prevention. Where does the nurse intervene here, given current trends?
Well, the education has to start early, covering tobacco, alcohol, illicit drugs. And while overall use by teens has seen some decreases, the current landscape has some really specific challenges.
And what are those trends that the sources point to?
We've seen a stabilization, not a reduction, in marijuana and alcohol use. And researchers think that's because of easier access and a perception of lower risk, especially with legalization happening in many states.
And then there are things like club drugs.
Right. There's continued concern over drugs like ecstasy or MDMA, which carries this severe risk of fatal hyperthermia, where the body temperature gets dangerously high. And of course, the nurse has to integrate prevention education about the ongoing opioid crisis.
It sounds like the nurse's intervention has to go beyond the student to the whole family.
It has to. Primary prevention here includes teaching parents about securing their own prescriptions at home, modeling safe use of legal substances, and critically, recognizing the early warning signs of substance use disorder in their own kids so that early intervention can happen.
And finally, under primary prevention, we have the foundational population-level mandate of vaccinations.
Yes. All states mandate specific immunizations for communicable diseases, DTaP, MMR, polio, as a condition of coming to school.
So the nurse's main responsibility is tracking all of this.
It's twofold. One, staying current on all the complex and varied state immunization laws, and two, maintaining meticulous confidential records for every single student.
That sounds like an immense administrative burden, especially if the nurse is only part-time. What are the logistical challenges?
The biggest one is just tracking down missing data,
Hmm.
especially for transient populations like military families or those experiencing homelessness. They might not have complete records or a consistent doctor. The nurse often starts sending translated notes home a year in advance of required boosters just to get ahead of it.
And that logistical challenge is really amplified when we talk about TB screening.
Oh, absolutely. The mantuberculin skin test, the TST, it has to be read exactly 48 to 72 hours after it's given. If a nurse only works 3 days a week, they might give the test on a Monday, but the reading window falls on a day they're not there.
So the screening often gets shifted to the pediatrician or the health department.
It does. But if a test is positive, the nurse's public health duty is immediate. They have to notify the health department so contact tracing and screening of everyone who is exposed can start right away.
And how does the nurse help vulnerable families who face financial or access barriers to getting vaccinated?
They become a resource navigator. They have to let families know that the Affordable Care Act requires insurance to cover childhood immunizations without copays. And they guide families to federal and state programs that offer free or low-cost vaccines for kids who are uninsured or underinsured.
And the school nurse can directly impact community-wide immunization rates through flu shot campaigns?
Correct. The CDC recommends a seasonal flu shot for everyone 6 months and older. With parental permission, the nurse can give the vaccine at the school or coordinate mass clinics with the local health department. It's a fantastic example of school nursing impacting the entire community's health. It lowers infection rates, cuts healthcare costs, and reduces missed work days for parents.
Moving on from proactive prevention to early intervention, let's talk about secondary prevention. This is screening, monitoring, and providing direct care for ill or injured children and staff. And this is the bulk of the nurse's daily work.
It is. Secondary prevention is all about immediate assessment and intervention. In the clinic, the nurse is constantly assessing and treating common complaints, from a sudden high fever to a playground injury. But their assessment skills have to be really attuned to subtle cues.
So, using assessment to look beyond the presenting complaint.
Exactly. They have to recognize that these vague, frequent somatic complaints, the recurring headaches, the stomach aches with no clear physical cause, might actually be indicators of something deeper.
Like bullying or stress at home.
Harassment, bullying, emotional distress, problems at home like hunger or family instability. The nurse's clinic is often the first place these complex psychosocial issues get identified.
And that high level of clinical judgment is critical when we discuss the nurse's leadership role in disaster and emergency preparedness.
The school nurse has to be the expert leader in all four phases of emergency management: planning, response, recovery, for everything from a fire or tornado to a school shooting or an acute health emergency.
So walk us through the NASN's recommended role for the nurse across those four phases.
Okay, phase one is prevention mitigation. The nurse is constantly assessing to identify hazards, anything from a trip risk to bad ventilation.
Phase 2, preparedness.
Here, the nurse is on planning groups, setting up emergency contact teams and developing detailed checklists for every possible crisis scenario: what supplies you need, where to evacuate, who talks to the parents.
Phase 3 is the response.
This is triage. The nurse is performing rapid assessments, coordinating first aid efforts by other staff, giving direct hands-on care, and acting as a crisis counselor. Helping students and staff cope, even by just recommending they reduce TV viewing of the disaster.
And finally, phase 4, recovery.
The nurse provides critical direct support and acts as the liaison, connecting students and families to long-term mental health or community resources after the event.
And beyond these school-wide emergencies, individual students can pose their own unique emergency risks.
And that's where individualized emergency plans become mandatory. These are required for any student with a health risk that could escalate fast, like severe food allergies, severe asthma, epilepsy, or diabetes.
What needs to be in those plans, especially since the nurse might not always be on site?
The plan has to have the student's complete medical history, a precise list of medications, the exact location of emergency meds like an EpiPen, and, crucially, a list of trained personnel teachers, administrators, who are authorized and trained by the nurse to give those life-saving drugs if the nurse isn't there.
And what about essential emergency equipment? What has to be in every school?
Well, all personnel should be certified in CPR and AED use. And the automated external defibrillator, the AED, has to be centrally located, highly visible, and unlocked for immediate access.
And the nurse's office needs specific supplies.
Yes, epinephrine auto-injectors, oxygen nebulizers, different sizes of blood pressure cuffs. And for the nurse themselves, advanced training like Pediatric Advanced Life Support, PALS, is incredibly helpful.
Okay, let's address one of the most legally and clinically sensitive areas: medication administration and delegation. What are the absolute non-negotiables for giving out meds in a school?
Safety is everything, and it hinges on multiple checks. You need a current, signed parental consent form and approval from the primary care provider with directions. The medication has to be in its original labeled container.
And confidentiality is key, but you still need to communicate.
Right, you have to follow HIPAA and FERPA, but you must get parental consent to talk to the prescribing doctor and to the teachers about potential side effects they need to watch for.
This brings us to delegation, which is often necessary, especially for part-time nurses. What are the challenges of delegating care to unlicensed assistive personnel, or UAPs, in a school?
Delegation is vital for continuity of care. It's what allows a lot of complex kids to even attend school. But the challenge is massive. There's a high legal liability and a huge training burden. The nurse has to train and continuously supervise UAPs to do tasks that can range from giving a pill to complex procedures like G-tube feedings.
And this is a direct application of QSEN concepts, quality and safety education for nurses.
Exactly. The nurse has to follow the 5 rights of delegation and their state's Nurse Practice Act to the letter. So, for example, if a nurse delegates the use of an emergency inhaler to a teacher, they're implementing QSEN. They have to establish open communication, create a clear documentation system to track use, and ensure a non-punitive culture where any error or near miss gets reported and evaluated.
And if the UAP can't be trained adequately.
The nurse must decline delegation. Safety first.
Now let's talk about the mandated screenings that fall under secondary prevention.
Most states require screenings for vision, hearing, height and weight, oral health, TB, and scoliosis, and the nurse maintains all those confidential records.
We touched on the logistical challenge of TB screening earlier, but it's worth repeating.
It is, because that 48 to 72-hour reading window is just incompatible with a part-time nurse's schedule. It often shifts the burden to the family's pediatrician. But the nurse still has that vital public health role of managing any positive results. A positive means immediate health department notification to start contact tracing and contain any potential spread.
They also screen for chronic disease precursors like hypertension.
Yes, an early identification of high blood pressure in kids is crucial for preventing long-term adult health problems. They also often facilitate sports physicals for uninsured or underserved kids, which is a powerful case-finding opportunity and a chance to provide targeted health education.
Let's tackle one of the most frequent yet highly controversial issues, pediculosis. Lice, this topic just brings out maximum anxiety.
It's a perfect example of where evidence-based practice has to confront myth and emotion. Lice is incredibly common, but the key fact the nurse has to stress is that it does not spread disease and it is not linked to poverty or poor hygiene. It's just a nuisance.
And the consensus among all the major health bodies, NASN, AAP, CDC, is strongly against routine screening and especially against no-nit policies. Why is that?
There are 4 really compelling reasons. First, misdiagnosis is rampant. It's hard to tell a nit from a piece of dandruff. Second, transmission of nits is highly unlikely because they are glued to the hair shaft and need body warmth to hatch.
And third, these exclusionary policies lead to a huge loss of academic time.
A huge loss. On average, 4 days per year per child. That costs schools and families money. And fourth, it results in stigma, privacy violations, and side effects from parents misusing harsh chemical treatments out of panic.
So the nurse's mandated role is to replace that anxiety-driven policy with education and evidence.
Exactly. They are mandated to provide accurate health education, advocate for less exclusionary policies, and support the current research-backed treatment recommendations from the AAP and CDC.
And finally, within secondary prevention, there's the very serious duty of mandated reporting.
State laws are absolute on this. The nurse must report suspected cases of child abuse or neglect to legal authorities and the principal. The nurse maintains a confidential file of their clinical observations, but then they have to step back and let the government agency, like Child Protective Services, conduct the formal investigation.
And how do they balance the emotional weight of that with the need for clinical objectivity and communication?
It's incredibly difficult.
Yeah.
They maintain objectivity by just documenting facts and observations. And when they're communicating with a family or referring them to an outside provider, even for a non-abuse issue, the nurse has to be really sensitive to parental health literacy. A written report is necessary, but a direct phone call or an in-person meeting is so much more effective. It lets the nurse explain why the child needs follow-up and build trust.
Okay, we shift now to the final level, tertiary prevention. This is all about caring for children with chronic illnesses or complex needs, helping them achieve the highest possible function and preventing complications. And this is a massive, growing part of the job because of those IDEA mandates.
School nurses are absolutely critical members of the Individualized Education Program, or IEP, team for any student whose condition affects their learning. This requires continuous case management to coordinate all the medications, procedures, and therapies they need throughout the school day.
Let's dive into some specific chronic conditions, starting with allergies and anaphylaxis.
The prevalence of severe allergies is just increasing. Common triggers are peanuts, tree nuts, milk, eggs, insect stings. The nurse has to be the leader in developing these multi-layered prevention plans to minimize exposure and, critically, manage emergencies. They provide mandatory annual training to all school personnel on how to properly use an epinephrine auto-injector.
And there are legal allowances for administration.
Yes, many state laws allow students who are developmentally ready to self-administer their own EpiPen, and they also allow trained UAPs to administer the medication if the nurse is off-site. The key is training, placement in an unlocked, accessible location, and a constantly updated emergency plan.
Next, asthma. This is the leading cause of school absenteeism due to chronic illness.
Tertiary management for asthma is so complex because it's both clinical intervention and environmental advocacy. Time missed from class directly impacts their education. So the nurse has to identify and address common environmental triggers right there in the school building.
Like chalk dust, molds, even fumes from buses.
Chalk dust, mold, strong cleaning perfumes, exhaust fumes from idling buses, absolutely.
And the sources mention the EPA's Indoor Air Quality, or IAQ, checklist. How does a nurse use a technical tool like that?
It's a really practical public health tool. The nurse uses the IAQ checklist to systematically track student health complaints. They look for patterns. For instance, are symptoms flaring up only in certain classrooms? Do they get better when the person leaves the building? The checklist helps them document concerns about ventilation, chemical storage, and push for safer cleaning solutions.
And the nurse's specific tertiary care for asthma.
It includes giving rescue medications, teaching kids and parents about allergen reduction, and advocating for those big systemic safety changes, like pushing the school to improve ventilation or switch to hypoallergenic cleaning products.
The case management for diabetes mellitus, both type 1 and the increasingly common type 2, is arguably one of the most time-intensive tertiary responsibilities.
It demands just meticulous planning and constant vigilance. The nurse has to be trained to continuously monitor blood glucose, administer insulin, often with a pump or a pen, and manage other medications. They have to be ready for acute hypo or hyperglycemic reactions, making sure emergency glucagon is available and staff are trained to use it, and they're vital consultants for the cafeteria staff, coordinating special diets.
Let's talk about students with neurodevelopmental and behavioral needs, starting with autism spectrum disorder, or ASD.
Children with ASD face really unique challenges in the school environment related to social skills, communication, and often other medical issues like seizures or GI problems. The nurses serve as critical advocates. They collaborate with parents who often report frustration with fragmented services outside of school. They give meds and suggest accommodations, like communication devices.
And for students with ADHD, attention deficit hyperactivity disorder.
The nurse's role there involves the daily administration of prescribed medications and continuously monitoring for side effects, like a decrease in appetite or sleep problems. They also have to advocate for the student against staff frustration and help facilitate the development of behavioral and time management skills.
Now we have to address the most difficult area of tertiary prevention, suicide prevention. The data for teenagers is just staggering.
It is a profound concern. Over 17% of teenagers report having seriously considered suicide, and over 8% have attempted it. The nurse has to understand the complex risk factors: social problems, bullying, academic stress, confusion about gender identity, and also the protective factors, like strong family and religious ties.
So what are the nurse's direct, immediate actions when a student expresses suicidal intent?
The response has to be immediate and professional. First, you ask directly about their suicidal intent. Second, you deny them access to any means of self-harm. Third, you monitor them continuously. Fourth, you notify the parents immediately. This is often a mandated report. And fifth, you call emergency services if an attempt is suspected or imminent.
And after a suicide?
The nurse coordinates grief counseling for the whole school community and has to assess for potential suicide clusters among friends and peers.
Relatedly, let's discuss violence and bullying, which often shows up in the nurse's office as those psychosomatic symptoms we talked about.
Violence is a significant public health issue on campus. In 2015, 6% of students reported being threatened with a weapon, and 23% were in a physical fight. And bullying is defined as that repetitious, unwanted, aggressive behavior intended to cause harm. It often targets vulnerable groups like LGBTQ or disabled students.
So what are the nurse's prevention strategies here?
Prevention involves facilitating student connectedness, supporting anti-violence policies, advocating for more adult monitoring in hallways and playgrounds, and leading education on gun safety. In the response phase, the nurse coordinates emergency care for injured students, uses crisis intervention to de-escalate conflicts, and identifies students who need in-depth counseling and referrals.
Finally, we have to touch on the sheer weight of complex clinical care and the ethical dilemmas that come with it.
Yeah.
Reiterate the clinical depths we're talking about here.
The specialized procedures are extensive. We're talking about fetal line maintenance, tracheotomy suctioning, gastrostomy feedings, urinary catheterization. The nurse is often supervising health aides and has to teach other school personnel how to provide this care if the nurse is off-site. It's a constant, specialized training role.
And managing care for children with HIV/AIDS presents unique challenges around confidentiality.
Confidentiality is paramount. Because of strict privacy laws, the nurse may not even know the student's status. If they do, they maintain the strictest confidentiality. No information is shared with teachers or staff, They ensure universal precautions, based on OSHA requirements, are practiced by everyone, and they help develop curriculum to prevent transmission and reduce stigma.
And perhaps the most difficult ethical topic of all, coordinating do not attempt resuscitation or DNAR orders at school.
Because IDI requires children with terminal illnesses to attend school in the least restrictive environment, a child may come to school with a DNAR order. Legally, this requires a formal, specific request from the parents and the physician to the school board.
And the nurse is central to that process.
Central to coordinating that extremely sensitive communication, they have to ensure the order is understood and respected. And tragically, if a death does occur at school, the nurse leads the immediate grief counseling response for the entire community.
This level of autonomy inevitably leads to ethical challenges, where a nurse's personal beliefs might conflict with the care required, like providing information on abortion or emergency contraception.
This is a critical point of professional ethics. If a nurse's personal beliefs conflict with the mandated care required by the school nursing scope and standards of practice, the nurse must never deny or ignore care.
So what is the ethical mandate?
The mandate is clear. They must refer the student to another health provider or resource who can offer the necessary and legally available care. The student's right to access health information and care must always be prioritized over the nurse's personal convictions.
Okay. To recap this deep dive, we've seen that school nursing is a profoundly autonomous, highly complex public health practice, and is driven by key federal legislation like IDEA and ESSA.
Right. And the core mission is enabling academic success by optimizing student health, which is a true population health approach.
And this mission is achieved through this huge array of professional roles: direct caregiver managing complex medical needs, case manager coordinating IHPs, consultant influencing policy, and it's all guided by comprehensive frameworks like the WSCC model and the NASN's 21st Century Framework.
And that prevention is segmented. So primary prevention is those large-scale efforts like immunization tracking and health education. Secondary focuses on emergency response, screening, and safe delegation. And tertiary is dedicated to the long-term, high-intensity management of chronic conditions like diabetes and asthma and dealing with those complex ethical issues.
Looking ahead, the expansion of healthcare in schools is only going to continue. We're probably going to see a greater role for telecommunication in care coordination.
Especially in rural areas.
Right. Allowing school nurses to connect students in rural or underserved areas with specialists remotely. And all of this will still be guided by the NASN's framework, with its emphasis on leadership and quality improvement.
Absolutely.
So what does this all mean for you, the future public health advocate? The health status of a student often dictates their capacity to learn and succeed. But despite all these complex legal mandates, many U.S. schools still lack a full-time registered nurse.
It's a huge issue.
So given the data we talked about, that a nurse's presence is tied directly to reduced absenteeism, how can future nurses leverage their public health skills, their knowledge of the WSCC model, and their access to data points like attendance rates to advocate forcefully for policy changes that ensure every single student has direct, daily access to the care they need to succeed? That is the ultimate challenge of this specialized, population-focused practice.